Hello everyone, welcome and thank you for tuning in to this case-based discussion about point-of-care ultrasound for ascites. This is primarily targeted at our third-year internal medicine clerkship, but again could apply to any situation where you might see ascites. This could be in anybody in an office, this could be in the emergency department, this could be an inpatient service, and really applies to a lot of different specialties where we encounter patients with ascites. We really just have one case to talk about here. This case is a 49-year-old male who presents with increasing abdominal distension. The patient has normal vital signs, and we can see stigmata of liver disease that are evident. We see some images here, and we'll go over those in a little bit more detail. So the reasons we care about doing this, or why we might do it, is one, just to identify ascites, to find the best location to perform paracentesis and look for the structures to avoid. And the real big benefits are this can just really expedite things a lot. Instead of kind of waiting around, ordering other imaging, or guessing where's the best place to place your needle, this is something you can offer at the bedside almost immediately if you have point-of-care ultrasound available. So you can do this in your office, in a clinic, if the patient's admitted to your inpatient service. We do this in the emergency department. It just really expedites care and helps you make decisions a lot quicker. So let's go over just a few things about the general techniques and general findings. We'll review a little bit of just some basic abdominal findings as well. Mostly you're going to use the curvilinear transducer for this. You could use the phased array if that's all that you had available. Let's just look at a few normal things just for quick refresher what normal bowel looks like. There's a couple different ways normal bowel can look. If it's filled with air, you'll get these kind of bright white bubbles of this air signature with these streaky shadow artifacts or dirty shadows. Over here's another example where we see bowel gas and then these streaky shadows. So that's one of the appearances of what the normal intestines can look like. Here's another example here with a linear probe. Again, we see these air signature images with kind of shadowing behind. If it's filled with stool, it can look a little bit more like this. So we see the outline of the intestine, but then it's filled with this kind of grayish, kind of mixed echogenicity stool. And here where it's kind of partially filled, we can see the multi-layered appearance of the intestinal wall. We see some of the interstitium, but then also some air with some shadowing from the air within the intestine. And then when it's completely empty when the intestine is completely empty and there's really nothing in it, we can see kind of circumferentially the multi-layered appearance of the intestinal wall with the echogenic interstitium contained within. This is another example. When you see this kind of white, black, white, multi-layered circumferential appearance, that's almost always intestine. So don't mistake this for another structure like an ovary or a gallbladder or something else. This is just a loop of intestine, a little piece of intestine that's completely empty, and you can see all the way around it. A few more examples. Again, this is with the linear. We can see this spaced out haustra here, so we know this is large intestine, and then it's just filled with air and then streaky shadows. Sometimes if you're over on the left, you may see a very distended stomach kind of in between the spleen and the kidney, and lots of intestinal contents. You'll see this more commonly these days with the advent of medicines like semaglutide and things like that. And it's always good to know, sometimes you see these patients who say, my belly's full of fluid, I'm here for this fluid, and it's really something else. Sometimes they just have gaseous distension, sometimes they've just got subcutaneous fluid and they think it's intra-abdominal, or they may have a bowel obstruction or an ileus. So these are just examples of really dilated loops of intestine that are filled with fluid. Remember, with bowel obstruction you get alternating fluid and air filled intestinal loops. We see here the plicae. Sometimes this is called the piano key sign. Again, here lots of dilated fluid filled loops of bowel with plicae, where the plicae are evident, so we know that this is small bowel. Just another example here, fluid filled small bowel loop evident from the visible plicae or the piano key sign. Or maybe the patient, if it's maybe it's a female patient, they have a giant ovarian cyst that takes up the entire abdomen. I've seen these cases as well, where maybe they think it's fluid, but it's actually a large fluid filled, or it could be solid, it could be some other abdominal mass. In this case, we have a fluid filled, somewhat complex. In this case, it was a large ovarian mass. Certainly not going to want to do a bedside tap for ascites if this is what you see. And then a quick reminder of just where the fluid will go. This is a refresher of what the potential spaces in the abdomen are. We think about this a lot in trauma and fast exams, but this also plays a role when we're looking for ascites. So most of the time ascites is going to be simple, so it should look pretty black. Here it is in the right subdiaphragmatic space and in Morrison's pouch. Don't forget to look in these paracolic gutters. This is where we're going to find it most, and where we're most likely going to tap it if we're jaining ascites. Here it is in the left subdiaphragmatic space and a little bit in the left paracolic gutter. And in the pelvis, you'll see it mostly dependent to the bladder, but depending on how you slice it, it could look like it's all around the bladder, and depending on how much fluid there is. But here's some in the dependent area behind the bladder, like here. And then in the female patient, we may see it's going to go to that rectouterine pouch first in the female patient. So here's the uterus and endometrial stripe. We see fluid here in the rectouterine pouch. Similar appearance here. This is the uterine fundus. Not the clearest image of the uterine fundus you can see, but the fluid we see in the dependent areas in the rectouterine pouch behind the uterus. So those are the places to look for it. Fortunately, most of the time, if you're considering doing a paracentesis for ascites, it's going to be a pretty large volume, and you'll be able to find it in several areas in the abdomen. Let's just look at things to avoid. Mostly, we don't want to do a paracentesis on someone who doesn't have ascites, so you want to make sure you're not getting ready to tap someone with a mimic. And we certainly want to know, it's nice to know where those solid organs are in relation to where we might perform our procedure. So just taking note of where the bowel and the bladder, the liver, some of these patients have significant hepatomegaly or splenomegaly, so you want to make sure that the spleen or the liver or something is not in the path of your needle if you're getting ready to do a paracentesis. And of course the abdominal vessels. Something that's talked about a lot, a nice little board review, is the inferior epigastric vessels. You definitely don't want to hit those. It's tough to hit them, but it has been reported, so I'll show you how to look for those. Now, most of the time what I do is I just make sure I look in the abdominal wall and make sure there are no vessels in my expected path, but some people do like to map these out and look for the inferior epigastric vessels before they do a paracentesis. This is in this example here, we're kind of at the right mid to lower abdomen, and just to the right of the umbilicus, if you find the rectus abdominis muscle, those inferior epigastric vessels sit just inferior but still in the abdominal wall. So you'll see peritoneal lining, and you'll see kind of moving bowel gas and things underneath. So usually it's the artery flanked by two veins that are compressible. So if you really want to overkill, if you really want to map these out and make sure they're nowhere near the path of your needle, you find these. This is a transverse view mid-abdomen. Just find these and kind of trace them up and down and make sure you're well away from them for your procedure. So back to our case. Again, like I said, most of the time if we're going to tap this in the office or in the emergency department or on the inpatient side, hopefully we've got a pretty large pocket. That's not always the case, but a lot of times it is. So this is a patient with kind of obvious, severe, significant ascites, so a relatively easy target. I'm going to review just a few things about the procedure itself in case maybe you've never done it or it's your first or second time. The main indications are for diagnostic purposes. So if it's a patient with new ascites and we want to gain diagnostic information from that fluid, or in a patient with kind of known ascites, known chronic liver disease, but we're doing a workup for infectious process, spontaneous bacterial peritonitis is one of the more common indications that will be doing a diagnostic paracentesis. And then the other reason is just therapeutics. They've got so much fluid that they're developing symptoms like abdominal pain, abdominal distension. Sometimes they get so much pressure, it's pushing up on their diaphragms, it makes them short of breath. It can even get severe enough to cause bowel obstruction, urinary obstruction. So there are multiple reasons to do a therapeutic paracentesis in patients with large volumes of ascites. And diagnostic, small volume, you may just be drawing off like 10 or 20 cc's with maybe just an 18 gauge needle or an 18 gauge angiocath, sometimes what I'll use. But in therapeutic, large volume, you may need to get 4 or 6 or 8 or even 10 these vacutainers to continually pull off large volumes of fluid. There's several different drainage systems. We're not going to get into all that here today. Most of the time, if they have a nice large pocket, what I will do is a static technique where I just identify the best pocket, maybe mark the skin, and then kind of put the probe down, prep the skin, and do the whole procedure. If it is a small pocket, but I still need fluid for diagnostic purposes, then sometimes I may do a dynamic real-time guided procedure where you use a probe cover and a sterile prep, and kind of similar to like you would do a central line, only hopefully a nice easier pocket. So you can do this dynamically if the scenario calls for it. And I'll briefly mention the ascites Z-track technique. This is where you identify your skin entry point, you pull some traction on the skin, then you place your needle through. In theory, you withdraw your needle, and then when you let go of the retraction, the skin kind of slides up and then covers the hole, decreasing the chance for a post-paracentesis leak. So that's the Z-line technique, something you should use. Just another diagram kind of demonstrating that technique as well. If I'm doing a large volume, I like to just place a catheter and then often hand off the tubing to an assistant so that I can go see other patients and do other things, and then let an assistant help with completing the drainage or hooking up to some kind of suction or drainage system. Like I said, there's a lot of different ways to do this, but if they need a large volume, I don't want to be in the room. I don't have time to be in the room for an hour or 2 hours. So I like to place a catheter and then hand off the tubing to an assistant who can kind of complete the easy steps of just filling up vacutainer bottles or hooking up to a drainage system. That way you can move on to seeing other patients or doing what else you need to do with the other patients you have to deal with. And you can just come back when things are done and remove the catheter. So that's really it. This is a pretty straightforward thing. If you incorporate this, you can kind of expedite the care and how you manage your patients. And do this, you can do this in the office, on the inpatient service, in the emergency department. You can offer this in a lot of settings, all by just using point-of-care ultrasound to help you, one, identify the right thing and do the procedure safely. And that's pretty much what we said. Use point-of-care ultrasound to identify ascites, guide paracentesis. It expedites things. It's safe. Exclude mimics. Avoid trouble. That's really the extent of it. So I hope this has been helpful. Thanks for tuning into this session, and we'll see you in the next one.